And we're getting close to that hour. I just want to say welcome to everyone who has logged on or dialed in already on this Friday afternoon. We'll be getting going in about one more minute. The numbers are climbing as far as our participants. The agenda is in front of us. All right, I think we will get started. So welcome everyone, and thank you for joining us. We have a wonderful lineup today. This is our 15th webinar for the COVID-19 Healthcare Coalition. Our agenda is, as usual, to bring you relevant topics that relate to COVID. And now we're moving into the solutioning phase of developing the next phase of the pandemic response. We're very happy today to bring you a panel discussion on the topic of social inequities and health impact. We've learned a lot over the last 3 months as we deal with the pandemic, and we've had tremendous evolution of a lot of our social factors that have been highlighted through COVID, and we have learned a lot as a society, and we're now moving towards a phase of action. And so this is a very exciting time. We'll have our panel, will take up most of our time this afternoon. And then in the last 10 minutes or so, we have a presentation from one of our work teams that's been developing natural language processing tools for research. Some of our MITRE colleagues will be giving a brief presentation there about tools available to the whole network. I'll also mention to you that we do have our Friday webinar next week on June 26th, and then we'll be taking a break for the 4th of July holiday. And when we come back in July, we'll be meeting on Wednesdays at 2:30. So midweek, that will allow people who are enjoying the summer days on Friday afternoon to be able to do so. So without further ado, John Halamka, how are you doing today? And
well, all good. Now, you say there are seasons and there are days of the week. I just thought there was Zoom. Well, welcome, everybody. And so every week I have sort of a key word or key theme, and this week it's momentum. And what do I mean by that? So we saw this coalition of coalitions with MITRE's help, and MITRE's been amazing, launch this national, not only the website that they host, but a whole celebrity endorsement campaign is now live at the fightisinus.org, headlined by Dwayne Johnson, The Rock. Also includes Samuel L. Jackson, Helen Mirren, Kevin Jong, Daniel Day Kim. So take a look at the fightisinus.org. And Mayo knows this better than I because they host it. But since that thing went live just a little over 24 hours ago, there have been over 2 million hits, impressions for folks to go and donate convalescent plasma. And when I say momentum, okay, fine. So you're building public awareness, and this campaign will go on for weeks and probably be extended through generous philanthropy. But then there are all kinds of issues that we need to solve, like, oh, are there enough places to collect that plasma? How's it going to be divided up? Can you get a ride to the plasma center? And so the details that everyone is working through are at a finely grained level. You know, arranging with Uber and Lyft to get rides and figuring out if there are sort of deserts, if you will, where donation is hard. Do we do mobile vans for collection? So we're moving beyond concept and into execution and the details. As well, I think that there has been a really great effort that I've been watching around the country on things like contact tracing, laboratory testing, getting people back to work. And now people are asking granular details such as, oh, there are 7 different serology tests. What are the sensitivities and specificities of those tests? What do I do with a positive or negative result? How do I get follow-up? So I'm seeing entrepreneurs, members of our coalition, government, academia, and industry all working through these issues of how we truly operationalize these back to work programs with great transparency and sharing lessons learned. So it's pretty exciting, FX, that we just, as you say, maybe 15 weeks ago started with a how do we come together? And now we're asking questions like how do we get free Uber rides? And how do we build mobile donation centers? And how do we get to hyperimmune globulin clinical trials by the summer while collecting federated data from every EPIC and Cerner site in the country to answer questions of the day? So if that doesn't represent momentum, I'm not sure what does. So Jay, turn it over to you.
And Jay Schnitzer, I know you have been doing double duty in the last few weeks with a number of projects. Can you bring us up to date on your perspective?
So good afternoon, everybody. Jay Schnitzer here from MITRE. I love John's concept of momentum. I will double down on momentum and say that John, in some dimensions, we're probably getting acceleration above the momentum. And so there is, in a very good and very positive way, some terrific work that's going on in various organizations across the ecosystem to try to up our game in multiple ways with COVID-19. And you will be hearing very shortly, hopefully later today, this was already pre-announced, but more details will come out today about CMS's new commission to study nursing homes with respect to COVID-19 and lessons learned and best practices, and then how to make improvements in a very positive way. So that's going to be a future development. And then, as you all know, there's a tremendous effort underway with the federal government to do an accelerated vaccine manufacturing development and manufacturing program for COVID-19 vaccines, with the very aggressive timeline of having vaccine ready this fall, which is faster than has ever been done in the history of humankind in terms of vaccine development and deployment. So exciting things are going on. Lots of people are thinking very creatively, aggressively, outside the box, and doing things in ways that were never before possible, and all to the good, and much more to come. But I will turn it now back over to FX for this thrilling panel that we have scheduled this afternoon.
Thank you. And with rapid change, we always have a continuous call for leadership, and we're really fortunate to have three thought leaders and action leaders to discuss this important topic of social inequities and health impact. Susan, would you mind showing the first slide, please? Just as a reminder to all that the death toll from COVID and the ravage that it has on our communities is somewhat asymmetric. And this recent publication from Brookings is a report on CDC data that is trying to measure and show us quite graphically the variation in death rates between different racial groups, whites, blacks, and Hispanic Latinos. And we see that the death rate from COVID infection is twice as high in the Black community. This is, again, across the country. And this story keeps playing out. And obviously, in addition to the death rate, there's all of the suffering that goes with this, health and as well as social suffering. So this is the stage that we're going to be discussing today, how we got here, and what can we do about it. So we're very happy to have three leaders with us today. We'll hear a few minutes of comments from each of them in turn, and then we'll have open conversation. And I've asked John Halamka, Jay Schnitzer, and Brian Anderson to help facilitate some of these questions. We have the pleasure of having Chris Boone from AbbVie, Peggy Hamburg, our former FDA director, and Nicolette Lusant with us today. And we're going to ask them to each talk a little bit about their own personal stories and how they got to their current leadership roles, and hopefully throughout this conversation, we'll be thinking and asking the question about what can we do together? And I'm just inspired by what's occurred over the last 15 weeks through the coalition, realizing that we can do things together that none of us as individuals or even organizations can do on our own. So with that, I'm going to turn over the mic and the screen to Dr. Chris Boone.
Thank you, sir. All right, let me share my screen here, and we'll do this. All right, so thanks FX, Brian, John, and all the individuals that are affiliated with this webinar and this organization. I think it's certainly the right thing to do as someone who was spearheading this during my time at Pfizer, and now I'm at AbbVie. But in the spirit of this particular conversation and in light of the comments you just made, FX, I really wanted to channel my remarks on this particular issue, which is addressing healthcare inequities in Black America with real evidence, and really more specifically is the need to address the lack of clinical trial diversity in a post-COVID-19 world. Just so you know, these comments are not necessarily reflective of AbbVie. They're all mine, but if there's anything brilliant that comes out of this talk, then you can certainly attribute it to AbbVie. The things that are probably a little more controversial or not so intelligent, then you can attribute those to me. But just a little bit about AbbVie for those of you who don't know, because it is a relatively young company relative to the other biopharmas and biotechs that you may be familiar with. But the company itself is $50 billion in revenue, and that is the AbbVie and Allergan companies combined. Prior to the formal integration of Allergan into AbbVie, AbbVie itself had roughly $33.3 billion in revenue in 2019. We have now 30 products in mid and late stage development or under regulatory review, 60 programs in clinical research and development. But I do want to kind of, in light of this particular conversation, I want to highlight a few things. First thing, there's been more than $120 million in community engagement and philanthropy that supports Black communities. 32% of the workforce is comprised of historically underrepresented populations. And you have a total of approximately 47,000 colleagues around the world with both AbbVie and Allergan. I know many companies have gone on record and made their own public statements and remarks as it pertains to the systemic racism and racial injustices. AbbVie certainly went public with theirs. I advise you to go check it out. It talks about a number of things, including equality, diversity, and inclusion, clinical trial diversity, reducing health disparities, and of course the philanthropic support that the organization has given. But AbbVie itself has gone on record and say that we will stand against it, and we will do everything within our power to address these particular issues. But a little bit about myself, and let me say this. Let me apologize if these slides seem very disjointed. I totally developed them this morning, and not that I'm trying to be a procrastinator. There's just a lot going on these days. But so we'll try to ensure the flow of these particular slides. But just a little bit about me. I am Dallas native, born and raised. That's why you see my Dallas background. We had the great privilege of relocating back to Texas from the East Coast, but I do work in Chicago at AbbVie. Husband and father, big Dallas Cowboys fan, patient advocate, health informatics, and social sciences futures. But I think some of the things that you'll find particularly interesting is I have not spent my entire career in biopharma. I actually started in health systems and nonprofits and consultancies, and ultimately made my way to the biopharma world in hopes that I can make a bigger impact on the industry and for the patient. But I also moonlight as a professor at NYU, the Wagner School, and I serve on many, many boards and committees. That's me. Of course, you may have seen this quote a gazillion times, but it's something that's near and dear to my heart. And it's certainly something that is certainly timely for where we are right now. But the great MLK once quoted, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." We can talk about the context in which he delivered that quote, but I don't have a lot of time, so we won't go there today. But just expounding on what FX has said as it pertains to some of the aggregated mortality and death rates that we're seeing from COVID-19, obviously you can see for Black Americans, it's 61.6 deaths per 100,000. If you start to look at, which is double many of the other groups from Latino Americans, Asians, whites, so on and so forth. But this data is out there if you want to check that out. I do want to kind of highlight a quote that was made in 2018. I still always reference this quote because I think it's certainly worth noting, where Janet Woodcock said, I believe the clinical trial system is broken. I do not believe it serves the interests of the patients. And I would agree with her on that. So that's why we're having this discussion today. And if you think about it, many of the effective clinical studies must consider all ethnic groups. Exclusion can endanger populations. And just for context, when you think about in 1997, 92% of the participants in clinical trials were white. In 2014, we made progress. Only 86% of the participants were white. And I mean that facetiously, but the whole point of it is that right now, with many of the clinical research efforts that we have, they're not reflective of the general population, and thus it begs the question of whether these therapies are working in these particular subpopulations. And one example I would give you, this is a study that was put out there, and it basically talked about multiple myeloma and patients. And interesting about it is that African Americans make up 20% of the U.S. multiple myeloma patients and are twice as likely as white Americans to be diagnosed, yet they only accounted for 4.5% of the participants in multiple myeloma trials since 2003. So why is there I had to change this view real quick, sorry. I can't really see, okay, I can see. Go back. Why is there a minority participation gap? Well, I mean, you heard a number of things and you'll hear issues around trust, and that is absolutely correct, but there are logistical challenges, financial burdens, in addition to the lingering distrust that certainly many Black Americans have from past victimization and medical experiments. But when you start to think about some of the social determinants challenges that are there, you start to look at just some of the numbers. And I pulled this from some various studies that were out there. 245,000 deaths were attributed to low education. 176,000 deaths were due to racial segregation. 162,000 deaths were due to low social support. 133,000 deaths were due to individual level poverty. 119,000 deaths were attributable to income inequality. Why should we care? Obviously, as we're getting to, the diverse study populations are vital to the understanding of how these therapies work in these different patient groups. So that's extremely important. And when it comes to the African American community specifically, we know that these underserved communities could have improved access to these novel therapies. But more importantly, we know that it's obviously been on record that genetics and environment play a huge role in overall clinical outcomes. We want to make sure that type of data has been captured and analyzed. All in all, in short, diversity in clinical trials equals good science plus better medicine. And so now you probably have heard the term real world data and real world evidence in many cases used interchangeably, but that's not necessarily the case. I do love this quote from the EMA, the European Medicines Association, where they said, real world data holds the promise to substantially increase the effectiveness and efficiency of all processes in the development and utilization of medicines, from research and development to regulatory decision-making, pricing and reimbursement decisions to use in medical practice. But why is real-world evidence especially appealing today? Obviously, you have these regulatory incentives and pushes from the FDA, the EMA, the Chinese FDA, and so on and so forth. But I also like to point to the fact that now we have this abundance of data that hasn't quite been there before. We have the clinical data, obviously we have the administrative data, but we also have this data that's captured in unstructured ways where we're trying to get smarter in how we both capture and analyze that data through many of the analytical approaches, but also the tools and techniques that are out there through much of what you're hearing through natural language processing and other AI techniques. But I do love this, and pull this obviously from a 2014 publication, but it just depicts all the various real world data types. And in this case, when we're saying real world data, we're saying non-randomized clinical trial data, and how it's captured and what we can do to learn about these particular subpopulations and how we can really ensure an improved clinical experience, if you will, with the various therapies. But if you're wondering why, pharma companies actually care anything about non-RCT data, when you think about the use of it, it's really used in these different stages for a pharma company. In discovery, we certainly want to understand the current standard of care and the disease burden and unmet need. When you get to the clinical phase, we start to design many of our trials, and it gets into site selection, investigator selection, and defining clinical endpoints. When it comes to regulatory and safety, it does inform regulatory decision. And then you also have some novel study designs and pharmacovigilance or safety initiatives. When it comes to value and access, we want to be able to demonstrate the comparative effectiveness over other therapies. And then, of course, we have a number of discussions around value-based agreements, and then commercial, and then, of course, patient-provider, where you're informing clinical decisions there. There was a recent blog post posted by Travis May over at DataVan. I really appreciated what he did, because he really has summarized in many respects very key COVID-19 research questions that could be used with real-world evidence. And I just pulled a few of them just for the purposes of this particular conversation. He talked about disease characteristics as one category, and we've already talked about that. But if you think about it, understanding which comorbidities are correlated with severe outcomes. I think right now there's been a lot of speculation on what and how, and we still don't know enough about COVID-19 to really understand what comorbidities are actually contributing to this high mortality rate, especially in African Americans. But then when it comes to socioeconomic and demographic factors, you want to understand, does socioeconomic status even impact the risk of hospitalization and mortality? I mean, we can assume it does anecdotally, but those are things that we want to prove. And then when it comes to the safety and efficacy of therapeutics, which off-label drugs are being used in COVID patients, and does the genomic or physiological characteristics influence the effectiveness of that particular therapy? There is a tracker that the Milken Institute, actually, these FastCures actually has developed and established that essentially tracks all of the clinical studies that are happening as it pertains to COVID-19. Right now, they say there's 251 treatments under development, 169 vaccines. I pulled from that tracker a couple of the ones that are focused, that are AbbVie sponsored studies. The first being an antiviral study, which is the top one to your right, and then the bottom one being an antibody study. I think that if this particular tracker is interesting because it does track it globally. You can see all the different companies and initiatives that are and studies that are happening around COVID-19 for those of you that are interested. And that link is right there at the bottom left if you want to check that out. But there is a North Star in this situation. I think if real-world data and real-world evidence are to be effectively leveraged for public health purposes, there will need to be shared learning and collaboration across clinicians, patients, healthcare systems, pharmaceutical companies, and regulators. And I think that the coalition that the coalition being led by MITRE and these gentlemen that we have on the call is certainly indicative of that. But I could not go without saying this, because I thought this was pretty funny, with many of our companies saying that they were not embarking on digital transformation because it wasn't necessary or appropriate. But I think this cartoon pretty much encapsulates it by saying that digital transformation is years away. I don't see our company having a change anytime soon. And of course, that COVID-19 wrecking ball is looming right above. I think that the future and what we do lies in shifting from many of the transactional relationships that we have and forming much more strategic and sustainable cross-sector partnerships, which will be inclusive of many of our pharma and life sciences companies, where we're all interconnected and we're working through addressing these issues together. It's been certainly encouraging to see the level of engagement we've seen through this pandemic. And I think that in order to address these global problems, we have to work as a global community in order to do it. Here's my game plan. Of course, we couldn't leave without offering some ideas on what we can do. And I know these are things that both Brian and FX will facilitate as part of this discussion. But I think that, number one, we need to establish a shared vision for what can be done around clinical development and practice for all communities. We need to develop a joint plan of action focused on addressing systemic racism and inequalities and social determinants and clinical trial diversity. And certainly we need to continue to invest in many of these technological and analytical platforms that will enable public health surveillance for these subpopulations. But it has to be guided with certain principles that are rooted in trust, collaboration, and culture. The cultural transformation that's necessary, where we're shifting away from the very isolated or siloed approach to data sharing or even how we function. I think those days are certainly done. So, and that concludes my remarks. I'll pass it back to FX.
Thank you very much, Chris. We've got a bunch of questions already, but I think what we're going to do is hold those questions and move right to Peggy Hamburg. And Peggy, please do, for the audience's purpose, give us a little of your long background, because it's fascinating and I think instructive of a life well lived in earnest pursuit of better health. So please share that with us. Thanks.
Okay, thank you very much. Can you hear me?
We can.
Okay, great. Well, first, let me say how pleased I am to participate in this session and fascinating opening presentation. Many of the issues discussed were ones that I worked on when I served for 6 years as FDA commissioner during the Obama administration. My sort of opening remarks will be much less formal and really trying to capture the momentum of this moment. Today, of course, is Juneteenth, which marks an important moment in our history, the official ending of slavery. It also is a critical moment, I think, as we address issues of race and social justice, equity and inclusion in our country, in part because of the unfolding COVID-19 epidemic, but also because of our, sort of national recognition and horror at recent events involving police brutality and the senseless killing of George Floyd, but of course, killings that had preceded that, and sadly, ones that have already followed. So this is an inflection point, and I want to speak to that. In terms of my own background and journey, I'm a physician scientist, but I've spent most of my career in public service, starting actually after finishing my medical residency training in internal medicine as Tony Fauci's special assistant, and then working as assistant director of the National Institute of Allergy and Infectious Diseases. Went on from there to serve as New York City's health commissioner, first for Mayor David Dinkins, the first and only African-American mayor of New York City. I also served 3 years for Mayor Giuliani, went on to serve in the Clinton administration, and then in the Obama administration. On a personal level, these issues are very important to me. My grandfather actually graduated from Meharry Medical School in 1901, one of the historically Black medical schools in this country, and was a pioneer as a African-American surgeon in Jacksonville, Florida, who did very well until the Jim Crow laws became a significant burden on him and his family. My mother was the first African-American to be admitted to Vassar College knowingly. I'd had a previous student who passed, but they didn't take away her degree. So for a while they claimed her as their first, but appropriately the African-American community at Vassar said that wasn't good enough, because they would never have admitted her in the first place had they known. But so my mother had that pioneering credential, and then was the first African-American woman to be admitted and graduate from Yale Medical School. So I have deep in my DNA and in my experience the recognition of the challenges facing minority groups as they move through life and through their professional activities. I have been very, very fortunate to have had a remarkable set of opportunities in science, medicine, and public health, serving, as I said, at NIAID, New York City Health Department, and then FDA. And really want to commend this organization for addressing important issues in such a collaborative way and putting this issue of racial disparities in health and hopefully in other arenas on the agenda for action as well. As we look at COVID-19, we see how it has really shown a harsh spotlight on pre-existing, long-standing disparities in health. We know, certainly when I was health commissioner in New York City in the 90s, every single important health status indicator was worse in minority communities and in our poorest communities. You could just overlay the health status indicator graphics one on top of the other, and COVID-19 has demonstrated that in the most devastating of ways. We also know that as we have grappled to manage COVID-19 and to flatten the curve, that the economic disruptions and dislocations that have been necessary to undertake the social distancing and other measures necessary have produced serious and sadly, lasting economic consequences for our overall economy, but particularly for those living closest to the margin, and minority communities are overrepresented in that group. So it's been devastating, not just in terms of loss of lives, but loss of livelihoods, economic opportunities, and educational opportunities. And when we come out of where we are now, thanks, I believe, to some of the promising science that was just being discussed, we will still have to grapple with the persistent impacts of this economic damage that has been produced, that will exacerbate and prolong some of the hardships that we have already been witnessing and experiencing. So this is a critical moment. It's like we have sort of three intersecting crises: the health with COVID-19, the economic, and now this sort of forced recognition of a sad but important truth of structural racism in our nation that we have to address. We have to apply momentum, and we have to take action, and not just action in the moment, but sustained, committed action to make a real and enduring difference. And as we do so, we all have a role to play, whatever domain of life and work you find yourself in. And we have to look hard at ourselves and at the organizations and institutions that we're part of. And that's why I really applaud this group for the commitments that you're making. And we do need to really dig deep and ask hard questions, and it will be uncomfortable. But there is much that can be done, and we have to address it on many levels in terms of the education and training opportunities, the hiring and representation within organizations, the ability to assure meaningful and quality access to important health care, and not just medical treatment, but also recognizing the importance of social determinants of health, and that the ability to prevent disease, which is at the core of public health, depends on having healthy communities and access to appropriate food, information, and education, opportunities to exercise, support for these behaviors, and opportunities in the workplace, and really a recognition that we can and must do better. And I, of course, have been thinking in recent days about that quote from Martin Luther King that was just cited. Also of another quote from a leader in public health that some of you may have heard of, some of you may not, but the former director of the CDC back, I guess, in the Clinton years, William Peggy, also one of the people that designed the strategy that allowed us to eradicate smallpox from the earth. And he reminded us that the philosophy of public health is also the philosophy of social justice. And that has guided my career. And I hope that all of us can really take that message to heart. Thank you.
Thank you, Peggy. Fantastic comments. We're now going to introduce Nicolette. She is the executive director of Healthcare Ready. Their organization had their development after Hurricane Katrina as a response to a lot of the inequities in the system of care and the public health system. So she's going to talk to us about their work over the years and the evolution of that. So Nicolette, the other thing I'm going to do, because I know you're going to be touching on supply chain, we actually have a supply chain work group that's been very active in the coalition, and they are interested in developing a group of people from the coalition to help them with their, get feedback on some of the programs that they've been developing. So I'm going to put a chat in the window if people can send their name on to Taylor Wilkerson, who many of you have heard on this conference before while we're listening. Thanks. So Nicolette?
Thank you. Good afternoon, everyone, and thank you for having me. It's always a pleasure to be with you all and to be following such esteemed colleagues. I don't know how much more there is to say from a public health perspective after Drs. Boone and Hamburg. So I'm actually going to take a slightly different tilt. One of the things that is unique about Healthcare Ready and my training and the work that we do is that we sit at the intersection of the health sector and the emergency management sector. And one of the things that has been quite complex as it relates to COVID response, but actually, if you think about it, responses to most serious and catastrophic events is really that cross-sector interplay, how the health sector is one of the most critical sectors as it pertains to restoration of the system, protection of survivors, continued care for those who may not have been directly impacted, but have sustained needs. But the ways in which emergency management and public health intersect can often make it challenging. And one of the challenges that I currently have serving on FEMA's National Advisory Council as a public health representative is actually understanding the role that equity plays in emergency management and asking the hard questions as it pertains to outcomes that we see after disasters and the ways in which we actually need to be working together to have a better understanding of not just response, but also that mitigation and preparedness posture. And from my vantage point, a big component of that is really understanding what it looks like to have a preventative public health model and a health preparedness model that fully integrates the health sector at all points of the supply chain so that we know our readiness posture with a lot more granularity, and we're able to make sure that there is minimal disruption to patients as it pertains to continuity of care. So I do know that there are a lot of questions in the chat. I just want to make a few points as it pertains to COVID, and then share a few slides from some data that we recently collected. From our vantage point, our challenges as it relates to COVID and vulnerable communities, first and foremost is the age-old problem in emergency management, which is identifying vulnerability. When we are thinking about hazards, especially all hazards, there's often a challenge as it pertains to being very clear as it focuses on medical fragility and true social vulnerability. So for our vantage point, we've continued to see outcomes as it pertains specifically to deaths from COVID, but we have not really gotten the time, the data, the ability to dig into the root of that. So our lens has really been trying to understand not just what the outcomes are as it pertains to the number of individuals who have been infected and died, but what is driving that? What are driving those rates of infection? Because that is really an emergency management and a public health preparedness question. And from our vantage point, a lot of that has really centered around increased exposure and then that medical fragility question. And as Dr. Boone mentioned, we still really don't know enough about COVID or SARS-CoV-2 to really understand the comorbidities, and we're still getting that data, but we know enough to know that there are certain populations that will have disparate impact once infected. But this is where we have to back out of the health realm and really think about the overall system that we're all interacting in, because then there are questions around exposure. I just saw a stat yesterday that said only 1 in 5 people in the United States have the ability to telework. So if we're thinking about increased exposure and we're talking about stay-at-home orders, which populations are in the essential worker workforce? Which populations have to maintain grocery and retail and other functions? And what does that look like, not just from a racial perspective, but from a medical fragility perspective? And so for our vantage point, as we are navigating this response, the various phases that are happening as it pertains to not just stay-at-home orders, but reopenings, understanding the intersection of concurrent events. We are now in hurricane season, and NOAA has predicted a very active hurricane season, which could actually mean additional challenges, especially for those in the Southeast. We are trying to not just understand how individuals are faring COVID, but also how they are preparing for disasters at large. And so when we think about that exposure question, going back to that increased exposure, we also ask ourselves a lot of questions about how we know preparedness is happening at the individual level. And one of our challenges a few years ago that we realized is that while we have data on outcomes, and one of the challenges as it relates to disasters and disease outbreaks is that normally morbidity and mortality are our most consistent public health measures. But we don't have anything about behaviors before disasters. And so while a small step, one of the things that our organization decided to do was to actually invest in conducting surveys on an annual basis to have a better understanding of not just what people were doing as it relates to whether or not they were taking some of those traditional preparedness behaviors, but what they were concerned about. And our hypothesis was essentially that there are more individuals that are aware of their risk, and that the individuals that we would consider to be socially vulnerable and medically fragile, often people of color, often individuals with low income, are probably more acutely aware of their risk, but being concerned and being prepared are not the same thing. And so from an emergency management perspective, we thought it was critical to understand how prepared individuals were and how concerned they were, because at the end of the day, we are going to have to pick up that slack. Whatever that gap is between preparedness and need is going to have to be met by the system if we are truly to find ourselves in a more equitable emergency management and healthcare response posture. And so I just want to, with a few minutes, share a few slides. I'm going to try to share my screen so that I can just show very quickly what we saw from the poll that we did this year. And this is the 5th year of this data. And just moving very quickly, what we try to do is make sure that we are getting a representative sample from across the United States. We do it around the same time every year, which is normally right before hurricane season. And we are asking a few questions. The first one being around, what are you most concerned about? And while we have this data stratified by race, age, region, I'm going to focus on what we see by race for this conversation. But what we see is that while most Americans are concerned about disasters, we are not concerned about the same types of disasters. So your race, your age, and where you live actually determines what you are most concerned about. And that makes sense. But it also means that the way in which we understand vulnerability and preparedness has to shift with this recognition. But of note is that this year, what we actually saw was a significant jump in our Black respondents, indicating that not only were they less concerned about a natural disaster than a disease outbreak, but they're more concerned about a novel or emerging disease outbreak, such as COVID. And then we asked questions about medical fragility. And this is just one of the questions that we ask, and we wanted to give this quick snapshot. What we find is that most respondents are saying that they are less aware of their medical information. And for us, from a vantage point, especially when we're thinking about all hazards, if you're in a sheltering situation and individuals do not have all of their medicines with them, and you're trying to figure out which individuals need what medicines, which is very common, not just in, you know, the large scale hurricanes, but tornadoes, large scale fires, any situation where there could be displacement. This is critical. And what we're finding is that most individuals are saying that they could not list all of their medication. But now let's look at this by race. And again, vulnerability is for us, one of the things that's very interesting about this is that we are seeing one of two things. We're seeing that there are breakouts that are different by race, but also that when we couple this with that sense of vulnerability, that for those hazards where we would need an individual to know their prescriptions, that we are seeing people of color, specifically Black and brown people, being more vulnerable. And then I'm just going to very quickly go through some of those measures of preparedness. And we do see that on a whole, Americans are saying that they are slightly more likely to be prepared. They're likely to take this action. They've not taken it yet, but they might. But when you start to ask this question by race, and you really start to understand whether or not individuals are saying that they would likely take these actions, we are seeing that Blacks and Hispanics are saying they're likely to take the action and more likely than whites, but that's unchanged from last year. So what I continue to wonder when we look at this is, if you're continuing to say you're likely to take it, but you've not yet done it, what is the barrier that is preventing you from being able to take this action? And again, this is just one of the measures of preparedness. There are a few others that we do like to reference, but these are just indications of the types of actions that we would need individuals to consider in order to be prepared, especially for a large scale event. Cash on hand is another, and what we do find across the board is that by race and by income, when we begin to stratify those, we see that individuals are saying they're likely to do it, but on a whole, we do find that Blacks and Hispanics are much less likely to have cash on hand. And so with that, we have a lot more data that is actually, we're putting it on the website right now. A lot of it's being stratified by race, but I did want to make sure that there was time for questions. So I'm happy to stop there and learn more from the group. Thank you for your time.
Thank you. Well, fantastic. Thank you to all. And it's obvious that from all the comments that, you know, there's a real interest in a data-driven approach toward addressing what we need. And I'm thinking you all touched on the needs for this concept of awareness of social factors in both the research as well as the preparedness, both ends of the spectrum. Can you just talk a little bit about the idea of our public health and healthcare systems? Many have said that they really are divergent, but in a well-organized society, they should be one and the same, public health and the medical care system. And just wondered if you could give us a few thoughts from your perspective and maybe what we can do together to foster that.
Well, maybe I'll jump in first, try to be quick, but you know, historically, public health has in this country been quite distinct from medical clinical care. When I trained in medicine, now many decades ago, I learned nothing about public health, in fact. But increasingly, I think we understand that so much of what's important for health does not happen in a medical care setting, and that many of the problems that we deal with once they're entrenched, in fact, can be either prevented or managed much more both cost effectively and in terms of burden on individuals and their families outside of the healthcare setting. But we have not developed the systems in order to really develop that, nor have we made the investments. It is increasingly clear that what we call social determinants of health are just enormously important in terms of the patterns of serious morbidity and mortality that requires the healthcare system directly. Yet we don't have that sort of network of both public health programs, community wellness programs, and social services that really allow us to bring down the risk of bad health and bad health outcomes by addressing social determinants of health. And sadly, as we're dealing with COVID-19 now, we are seeing some of the fallout, both in terms of the enhanced vulnerabilities of individuals, and particularly people of color, because of long-standing health issues that actually could have been prevented or minimized with better systems of care and stronger public health. But we're also seeing a public health system that can't cope with the current demands on it. Over the last decades, while we have seen an appreciation in some areas of how public health matters, we haven't seen the concomitant increase in terms of investments. In fact, if you look between 2008 and 2017, I think local health departments have lost about a quarter to a third of their budgets, and over 55,000 health workers. We need that infrastructure now as we're starting to talk about the importance of contact tracing and managing hotspots of COVID-19 infection, for example, and it simply isn't there and it can't be built overnight. So again, when we're talking about, you know, sort of critical moments in time and looking forward to how we can do better, really investing in public health and this network safety net that public health represents, as well as strengthening of important social services to allow people to thrive in their communities rather than get sick and need medical care, is absolutely essential to the future.
Thank you. Chris, I know you have a passion for the data, and you had mentioned to me when we spoke the other day about the idea of having information about social factors when it comes to medication adherence and understanding some of the other issues that relate to how can we treat patients and whether they're getting their medicines, whether they're taking them, whether they have the capabilities. Talk a little bit about the data that we have and how we can potentially act upon it, or how we have to improve that.
Well, I mean, I think that, you know, Dr. Hamburg hit the nail right on the head with much of her comments that she said as far as how we better incorporate the idea of social determinants into something as simple as the health record itself. But I think there's a number of different, we've relied heavily on clinical and claims data historically, and I think that certainly has to change. And as I as I alluded to in my comments, there's this abundance of data types that exist that tells us much more about the patient experience outside the walls of a provider environment. I think that we've done a number of things. And, you know, it's interesting because even with this pandemic, when it hit, we started to see a number of these novel data types being utilized. you started to see Facebook and Google highlighting the use of geolocation data to really determine if social distancing was really being enforced by many of the citizens. You saw there was a company based in New York who actually manufactures these smart thermometers, and they were able to use their data to hotspot whether patients were congregating and where you were seeing a temperature spike, which was an indicator that, hey, maybe COVID was spreading in those particular communities. And I think that's what you start to get is now these novel approaches and these novel data sets, which give us insight to then more effectively utilize the limited resources we do have to reemphasize Dr. Hamburg's point, and putting those into interventions that we hope can address and mitigate many of these problems. And I think that as we start to think about what does a true public health surveillance infrastructure look like, it has to incorporate many of these novel data types in order to effectively work. And I think that, you know, so to your point around data types, obviously we got these geolocation data, we got the data that's coming from many of the wearables, in addition to much of the unstructured data that comes from social media as we see what people are hashtagging and what they're searching for. So I think these things are collectively provide us much more insight into what patients and consumers are experiencing.
Great, thank you. Obviously, we could go on for quite a while. This is absolutely fascinating, and we hope to have each of you back as the weeks go on. We do need to turn to our last presentation of the day from Abigail Gertner and Tonya Corvus. They're going to actually be talking a little bit about the use of natural language processing to unearth data and unearth findings from not only the medical literature, but beyond that can impact our understanding of the world around us. So let me ask Abigail and Tonya to show us what they have. Tonya, I see you on. Are you going to be able to show your screen, Abigail?
I thought Abigail was going to go first, but I can jump ahead.
Well, whoever wants to start, it's fine with me.
Sure. I'll share my screen here.
Sorry, can you hear me now?
Oh,
Yeah.
We can hear you now.
Oh yeah, sorry, I was just having some trouble with my audio. Do we have a hard stop at 3:30 or should we?
Yeah, if you can show your screen and give us a thumbnail of what you guys have developed. I know we've had these materials posted on the website, and they've gotten increasingly better over the last 2 months, and it's exciting to share that with our community.
Okay, Tonya, why don't you go first then?
Okay, great. Let me share am I sharing my screen? No, here we go.
There you go.
Okay, great. Okay, I'm Tonya Corvus from MITRE. I'm going to demo the COVID-19 Therapeutic Information Browser. This is on the Coalition site. This is a tool for finding scientific information about potential drugs and vaccines for COVID-19. There are now about 30,000 COVID-19 publications. This is a lot to sort through. So to help the biomedical community easily find this information, we've developed a machine reading pipeline to extract drug and vaccine information at scale. Our pipeline processes PubMed abstracts, bioRxiv, medRxiv abstracts, and clinicaltrials.gov descriptions. To date, we've processed over 80,000 documents, and we update the results frequently and make them available here on this website. So over on the left on this, you see the menu. There are 3 classes of information: therapeutics, vaccines, host entry receptors. If we click on the therapeutics one, what we get is a table with viruses across the top and drugs down the side. These numbers in the table indicate the numbers of documents identified by machine reading for the particular virus. And so, for example, the number of documents found for remdesivir is 138. We also read for some research stages, so we have numbers of documents about those. You can go across and see information for other viruses, and you can go ahead and extend down to see information about additional drugs. There we go. And you can go ahead and filter by the date range nearby if you want to. To date, we read for about 13,000 different drugs, and we found papers for about over 500 drugs for COVID-19. So now you can go ahead and search for a particular drug of interest. working on my screen. There we go. Okay, so we'll go ahead and if you click on one of those numbers and scroll down, what you get then below is a list of the papers with those drugs. It links out to more information about the drug on Drug Bank. We show the publication date, the journal name or source, the title with a link out to the abstract. And the research stage, we read for 8 different research stages, such as whether it's in a cell line or in silico, or it's an emergency use case report. And you can sort by that so you can see papers of that particular research stage. And so not only do we have, most of our results are directly from machine reading, but we also have a curator in the loop so that you can curate, that you can see some information that's been vetted by a curator. And when that happens, the curator goes ahead and selects information directly from the abstract to highlight the particularly important results from that. And the curators also curate information about reported drug efficacy. That's about what the abstract says about how effective the drug was in the study. So that's the information browser. It's here at COVID-TIB on the Coalition site. And if we'd love to hear if this is potentially useful for you. We like to hear about new use cases. And if you have feedback or suggestions for features that would make this useful for your work, we'd love to hear about it. And you can reach us at the email address on our homepage. Thank you.
Thank you. And Abigail?
All right. Can you hear me okay?
We can.
Great. Okay, so I'm going to share my desktop over here. All right, so you should be seeing the COVID-19 topic browser now. Is that working?
It is.
Great. Okay, so I will just quickly give you a walkthrough of this tool. Similar to Tanya's tool, this is also available on the Coalition website under the natural language processing landing page. And this particular tool is a tool for exploring and discovering information in COVID-19 related literature. It's a little bit different from a normal kind of search engine because you don't come to this and enter a query and get search results. Instead, we're using a natural language processing technique called topic modeling to organize documents in topics. And the way this works is that it looks at patterns of words in the documents that frequently occur together to basically learn the topics. So what we have over here on the left is a list of topics in our topic model. Each topic is represented by the top terms associated with that topic. And then documents are associated with topics by finding the documents that are the closest to a topic in document space. This is not an exclusive clustering, so a single document may be associated with more than one topic. So there's several different ways that one might use this tool or use cases. One way is just to get a general overview of the whole corpus. So in this case, you can sort of scan through the topics over here, and you can see there's different kinds of topics. There's some that are about things like clinical studies or statistical cohort studies. And then there's other topics that touch on issues like psychological or mental health issues, social media, misinformation, that sort of thing. So there's a lot of different topics in this data. So I'm just going to quickly show you an example I wanted to bring up sort of related to the earlier discussion because I think that was such a great discussion and such an important topic. So one thing that you can do here is sort the topics in various ways. And I'm going to go to the search tool here, and we can actually just ask it to pull up topics that are related to race as a search term. And then it's going to resort the topics so that I can then see, even though actually race doesn't show up in the top terms here, we do see ethnicity, socioeconomics, some other related terms. If I then click on this topic, I can see, I then get a list of research articles from the literature that are related to the topic of racial and ethnic disparities in COVID-19 outcomes and related subjects. One of the main use cases that we think is important for a tool like this is for finding unexpected connections and sort of doing discovery. So it's not like a more typical search engine where you would enter a specific search term and your results are restricted to things that match those terms. Here you can really look at these and find connections that you might not have thought of. You can also see the trending of these topics over time and the timeline up at the top. And then you can actually click on these entries to look at the full abstract for each article. You can look at the related topics under here. The URL for the topic is actually encodes the selected topic in it, so you can save a topic as a link, as a bookmark using this URL, or even share it. And then lastly, you can also click on the title of the document over here to be taken to the official actual page for that article.
Well, thank you, Abigail.
So that gives you pretty much an overview of the tool. And yeah, that's it.
That's great.
Thank you for listening.
We've been putting the tools to pretty good use with our EHR data studies, which you'll be hearing more about in coming weeks. Next week, our panel discussion is going to relate to contact tracing, another topic that was mentioned today. And I just want to thank all of our panelists and all of our speakers today. Please continue the great work you're doing, and please continue to reach into the Coalition for Strength and hopefully the duplication or the magnification of your efforts. So thank you all and stay safe.
Thank you.
Thanks so much.